All right, good morning, everyone. Thank you for your presence here. We are so excited and thrilled to be launching Building a Movement, the launch of the National Overdose Prevention Network. We are both here in Sacramento and all over the country, 47 different states represented, over 400 folks in simulcast. We're thrilled to have you here. I'm gonna just kind of get us started now with some introductions and housekeeping. Let me draw your attention to the slides. As I was mentioning, we are a very big group of folks, 400 different registrants across 47 states. This is a bit of a movement snapshot. This is something really big and special that we're launching today that represents many years of kind of community-anchored work coming together. Let's get to know each other a little better. Everyone pull out your phones. We're gonna do some phone polling. All right, so first thing I'd like you to do is have your phone out. I want you to join the poll. You're gonna send a text. This is a number text, 22333. Again, 22333. And in that text, the message will say, Nopen Poll 609. Nopen Poll 609. So pull out your phones. We're going to use our phones this morning as a way to get to know each other and who's kind of with us as we launch this movement. Send a text to 22333, Nopen Poll 609. Maybe someone will just hold up their phone for me once you've received a little bit of an answer back. Excellent, excellent. It's happening all in real time. Fantastic. Let's appreciate some of the sectors that are being represented across this great movement that we're building. Again, using your phones, you're going to enter one letter, A through J. The different sectors and categories are represented. A for healthcare, B for public health. Can you see now? Look at the different numbers that are being represented already as people designate their sector. It's really fascinating. We have a really diverse, cross-institutional, cross-sector, cross-profession movement that we're building, and we need every single stakeholder to be a part of the solutions. Excellent. All right, and then with you're using your phones again, with just one word, type one word to describe what it means to build a movement around overdose prevention. So again, you're typing to 22333, one word to describe what it means to build a movement around overdose prevention. You all see the beginning of our word cloud here? And it's an imperative, it's community, it's powerful, awareness, momentum. It's necessary, it's success, amplified impact, destigmatization, inclusion, safety, crucial, high, hope, health, innovation. It's fascinating. This is amazing. Delivery, united, giving, and the word collaboration in the center. All right, lots of powerful words. I'm going to kind of move us ahead. We are thrilled to, and I'm thrilled to be able to introduce one of the real tip of the spear individuals related to this movement, Dr. Carmen Rita Nevarez. I've had the privilege of knowing Carmen for, it feels like almost 15 years. She has an incredible track record and body of work around community health and collaborative leadership, and also around sort of the testing and the creation of health innovation solutions. Carmen is a public health thought leader. She has served as the past president of the American Public Health Association. She serves on the board of many foundations, and she's actually, with all the other things that she's doing, finds time to practice as a community physician. Carmen will lead us into the next aspects of our time together.
Well, thank you so much, Milano, for that very kind introduction. I really am proud and so excited to have all of you here today and all of you in our listening audience. Part of what's really interesting about that slide that Milano showed is that we almost have every single state in the United States signed up for this 2-hour morning segment of what is actually a whole day for the people that are in the room. And I want to give a little shout out to the state of North Carolina, because North Carolina got 10% of the more than 400 people that were registered. So I don't know why, but North Carolina, thank you for being with us, because we really appreciate it, and we hope that you will help to spread the word. So let me just start by saying why we're here. We're here because we're building a national learning community to fuel local and statewide overdose prevention efforts. What I saw in the Wordle said something to me very, very personally. We're here about awareness, about building collaboration, and how powerful that is. In 2018, my organization launched a statewide forum for all of the coalitions in California that were confronting the opioid crisis. And what did we learn? We learned a lot of things that we thought really ought to spur us into action in connecting with people across the country. We learned that strong partnerships, leveraging assets already in the community, working across sectors, bringing everyone to the table, adopting what works and not reinventing the wheel really makes a difference. People do not have to do the same things and make the same mistakes that others do. There's a lot we can teach each other, a lot we can help each other with. So based on that, we actually now have enough people in California to cover 33 million Californians. That's what the coalitions are getting done, and it's really very, very exciting. So why do we think coalitions are important? Because they help to develop the local response by responding to community needs. The community gets to say, this is important to us. So there might be great federal policy or great state policy, but the communities themselves say, all of that's good, we need to focus on this other thing. And that's where we will help them to do that and help them to spread the knowledge and learn from each other. It's important because we're strengthening systems by generating dialogue between sectors. And you saw the sectors that are here present with us in the room and present with us across the internet, and that's really the strength of it. The strength happens when we all get together and try to understand and work with each other's perspectives and skills. And it's important because this is how we sustain action, by building and focusing on long-term solutions. So what's the how? We are helping to implement key evidence-based strategies. This is about poly-drug, not one drug, but many drugs. We all know that pretty much across the country, it's not just opioids anymore. We need to understand there are very dangerous combinations, and this is what we need to focus on and really start to put some effort towards. We need to look at upstream prevention and education, safer prescribing. We need to look at drug disposal and take-back. We need to be managing chronic pain safely through alternative pain therapies, tapering high doses, helping people to limit opioids and sedatives. We need to treat addiction. We need to be about accessing medications for addiction treatment. We need to reduce stigma. That's a big part of everybody in this room has a role in helping to reduce stigma. That step alone will help bring somebody a little bit closer to getting their life back. We need to stop overdose deaths. Many folks here are engaged with and also helping others to learn about administering naloxone. We need to think about what is the role for syringe service programs in our communities. We are about sharing the learning, about spreading the impact. We've learned there's a need for alignment across geographic and demographic communities. One of the things we learned in California is that if you're in one community, you know one community. There's such diversity here, and in partnering with other people across the country and learning from them, we found many solutions, we found many trials, we found many opportunities to share experience, and that's why we decided to come forward with this idea of building a national learning community. It just makes sense. We can't afford to waste time duplicating our errors and not making the connections when we can really help each other. We need to improve cross-sector learning. We need to really share innovation. We need to build more evidence-based knowledge. We need to work on communicating impact, because this is how we're going to change hearts and minds. So this is just a little quick scheme of what the National Overdose Prevention Network is how we think of it. Right now, it's a national learning community where we're connected via the internet, where we connect at meetings that we go to, where we connect by resources that we share, where we connect by giving each other the opportunity to learn from our mistakes and to absorb our insights, and where we all, as an entire nation, start to look at how do we change what's happening in this country with respect to substance use. This is a chronic disease. We need to treat it like a chronic disease. We need to grapple with it and move forward on this agenda. In this, we are all together a community of learners. So what's in it for you? Well, we'd like to see all of you participate in national conversations about best practices. We would like everyone to have access to proven evidence-based strategies from leaders and substance use disorder coalitions from across the country. We would like to see connection to innovative new partners from across the nation, representing a variety of economic, ethnic, rural, urban, suburban communities. We would like access to counsel and a wide range of customized support. We want enhanced ability to influence state and federal and local drug policy. And finally, we want to make sure that everybody is linked to resources and funding opportunities. So this is something that we can do with each other in a web-based learning community, and by leveraging every opportunity that we have when we meet with others. So, to become a part of this community, we ask that you go to www.NOPN, that's N-O-P-N, for National Overdose Prevention Network.org, and register, and we will get going. So first, let me present our first keynote speaker. It's really a privilege because she helped us to get started on this whole movement. Kelly Pfeiffer is the Deputy Director for Behavioral Health for the California Department of Healthcare Services. Dr. Pfeiffer was appointed by Governor Newsom in July 2019 to lead the newly reorganized Behavioral Health Division of the California Department of Healthcare Services. She practiced family medicine and is a former medical director of the San Francisco Health Plan and several health centers. And prior to joining the state, she'd been the director of high-value care at California Healthcare Foundation. While there, she received the highest award presented annually by the California Department of Public Health to an individual exhibiting outstanding leadership for her work, leading the California Healthcare Foundation's opioid initiative to end overdose deaths in California. So, with that, let me introduce Dr. Kelly Pfeiffer.
Thank you. Good morning. It's an honor to be here, and I have to start by a frank admission, which is I spent the first 5 years of my career fueling the opioid epidemic and the rest of it trying to end it. And like many of my generation, I'm a family doctor who was duped. I'm not in big pharma. I just believed the promise that opioid pills would help people and make them better. And of course, the opioids held great promise. People got better for a little bit, and then they always got worse. And like many of my generation, I saw patients become dependent on pills that they couldn't stop taking and ultimately end up with addiction. And I also got a call from a coroner one day, which made me wake up and realize I have to practice differently. Because we've learned some really hard lessons, that the brain can't tell the difference between high-dose OxyContin and heroin shot in a vein. What opioids do is they flood the brain with dopamine, and dopamine is the chemical in our brain that manages our reward system. We get flooded with dopamine when we have sex, when we eat, when we drink, when we're happy, and our dopamine levels plummet when we do things like isolate that put us into despair. So dopamine is really a survival chemical. And our brains are very fine-tuned to stay in this very, very narrow range. So when our brain gets flooded with dopamine, again, because whether it's from a pill taken, like your doctor said, the brain says, never again. We're going to ratchet down that response. We're going to be unable to make dopamine, kill off receptor cells. So your brain, over time, doesn't work the way it does before. And sometimes those changes are permanent. So you'll find people with long-term opioid use, again, whether taken by the doctor or taken from the street, have to get opioids every day just to function, just to get up to that level of dopamine that for the rest of us feels like kind of a bad day. That's what they're doing over and over and over just to stay alive. And so what we've seen is, as we've learned more about brain chemistry, we've learned how to treat this epidemic very differently. So there are solutions for how to get us from where we are to where we need to be, but it's not the path we've taken. And so doctors like myself, healthcare system has to admit, we made mistakes and we need to do different things differently. We can't pretend that there's anywhere near enough addiction specialists to treat people who are addicted to opioids or addicted to methamphetamine or addicted to marijuana. We in the healthcare system have to acknowledge that if addiction is a brain disease, and we've learned it is, then we in the practice of healthcare have to learn how to manage it, and not by ourselves, but with a community around us. And I would challenge my colleagues in law enforcement to admit that same mistake, that we've spent $1 trillion on the war on drugs, which led to mass incarceration of people of color who we know painfully are more likely to be arrested, get longer sentences, denied parole and probation for the same but often lesser drug crimes than white people. And our drug problem is nowhere near solved, and we can't pretend that people aren't dying of overdose in our jails and prisons. So we have to think differently. But fortunately, there are places that have cracked this nut, and we have seen overdose rates in some places drop by 80%. But it's not in this country. It's in places like France, where they've made treatment easier to get than street drugs, and doctors like myself can prescribe buprenorphine, get paid by insurance companies to treat addiction, not have to go through special waiver training, and they dropped heroin deaths by 80%. We've seen other countries that have worked really hard to make sure at every single touch point of law enforcement, people are pushed to treatment instead of jail. It costs less, people get better, people do recover. So I would challenge us on this day to hold ourselves to data and science. There are things that we know work. There's hundreds of things you could do to try and stop this epidemic. I would challenge us, there's 4 things that we really know how work, and we should work on them. So first, for people who have chronic pain, who are dependent on opioids, we can't just go back and say, oops, we made a mistake, we're cutting you off, I would just learn they don't work. Because when we do that, we put them in the hospital and often they die. Half the people cut off from opioids end up in the hospital and many overdose. If we're gonna help them, we have to take care of them. Second and key is we have to make treatment easily accessible at all touch points in our systems. In California, we call that treatment starts here. If you see your primary care doctor and you admit to a problem, we're training primary care doctors to be able to prescribe buprenorphine, to work with substance use specialist to be able to manage the more complex cases, treatment starts here. If you show up in now 50 of California emergency rooms, you can get a dose of buprenorphine and a substance use navigator to help you get into treatment. Treatment starts here. I'm so proud that in our prison system, we have made the commitment in every prison in California to make all substance use disorder treatments available that are evidence-based, and that includes buprenorphine, methadone, naltrexone, behavioral treatment. We're equipping our prisons to make sure that people don't overdose and die when they walk out the door. We're doing the same thing in our jail system. It's hard, slow work, but again, treatment starts here. Third, we need to embrace this concept of harm reduction, which I like to call treating people like human beings. Like, for example, how many of you have set a New Year's resolution? I'm going to eat better, I'm going to exercise more. Hold your hand up. And now keep your hand up if you kept that resolution every single day for 365 days without fail. Right? I mean, that's just human nature. We are not perfect, yet we expect people with drug addiction to be perfect. So imagine a culture where we said to people, we want to take you where you are. Come in, we'll help you. If you're not ready to quit, we'll give you clean needles. We'll make sure you don't get HIV. We will give you a warm place so that when you are ready to quit, we'll help you. Because what do we know about smoking, right? It takes 50 times to quit before you're ready to quit for good, and people relapse. That's the nature of addiction. Imagine a culture where we didn't take your kid away if you made a mistake, where you didn't go back and lose your freedom, where you didn't lose your job, where we embrace the fact that we're all human and we are all on a journey. So all of these changes, how doctors prescribe, how law enforcement treat addiction, are big culture changes. And this is what this day is about. The fourth thing that we need to do is we need to change our culture, and we can't do it alone. And that's where there's the power of coalitions and the power of the coalition network. So I want to tell you a little story. In 2015, when I was at the foundation and I was looking around saying, how do we do this? This is really hard, because people don't change because some state official told them they have to do something differently. They don't change because the AMA changed their guidelines or because the Attorney General said you need to do so. It's culture and it's local, and you change because the people you work with and the people you care about are all changing, and we change together. And the only way to do that is by engaging local leadership. So we said, look what happened in San Diego and Marin, which we'll learn about today. They brought people around the table. They put data on the table. This is our overdose rate. They created a call to action. They said, we can't fix this, doctors alone, or law enforcement alone, or addiction treatment alone, or advocates. We have to sit around and do it together. And they didn't sit around processing. They created goals and action, and they said, in 12 months, this is what we want to see. And it was powerful. So our foundation gave seed monies to about a dozen of these, and it grew and grew and grew. And I made a mistake, I admit, as a doctor. I just thought, people just need to know what to do. So we'll just tell them what to do, and it'll happen. And I will say a lot happened with us just focusing on, this is how you treat drug addiction, this is how you treat pain, this is what harm reduction is about. But people stalled. And what we learned is that any culture change requires strong leadership, and it requires the ability to communicate with people you don't know how to talk to, like you're not used to talking to. It requires the ability to admit you're wrong and say, I may not have all the answers. So we turned to the Center for Health Leadership and Practice at the Public Health Institute, and we said, help us, because healthy coalitions that get stuff done are healthy organizations. Healthy organizations need to learn the basics. How do you run a good meeting? How do you talk with people who don't understand how you work? And that was really powerful. And of course, the doctors were the worst. They were the ones in the coalition says, yeah, that's processing, because we don't like to talk about stuff. We just want to get stuff done. I think law enforcement's the same. But almost all those coalitions eventually came back and said, oh, you know that stuff about like process and capacity building and how to work together? But I think we need that. I think we're stuck. So this has been a force to be reckoned with. What's happened in California with all these coalitions in places that are like different countries. LA is very different than Trinity County, than Plumas County, but they've all come together, they've learned from each other, and we're really excited about leveraging what we've done, where we have red counties and blue counties, and we're all losing our children, and we're all working together to solve this. So I have great hope for a national network. This type of work of learning from each other and learning not just what to do, but how to do it, and how to create culture change that sticks, it worked. We have incredible opportunity nationally, both from you to learn from what we did in California, but even more importantly for us to learn from you. So thank you for joining us today.
I'm going to go ahead and introduce our next speaker from the panel table here. We are extremely fortunate to have Dr. Ronit Lev. We are going to see a video from her. Since she was unable to actually be physically with us in the room, she is the Chief Medical Officer for the White House Office of National Drug Control Policy. She's charged with providing medical leadership in coordinating drug policy across the federal government. While working on national health policy, she continues her boots-on-the-ground experience of over 25 years as an emergency physician treating the frontline cases of addiction. She's board certified in both emergency and addiction medicine, and was the chief of the emergency department at Scripps Mercy Hospital in San Diego. In 2012, she established and chaired the San Diego Prescription Drug Abuse Medical Task Force, the first of its kind in California, that integrated physicians of various specialties and practice settings, along with hospitals, dentists, and law enforcement. Dr. Lev's medical publications, known as the Death Diaries, studied the details of prescription patterns of people who died from accidental prescription drug overdoses, giving insight to the causes of overdose and directing prevention efforts. So with that, I'd like to ask that we run the tape.
Thank you so much for the invitation to be part of this webinar and conference across the country, and congratulations on the kickoff event for Building a Movement. Building a Movement is a wonderful title because it'll take a movement to make a difference in addiction, medicine, and overdoses across the country. A movement of healthcare, of law enforcement, of prevention, of faith-based organizations, of criminal justice, of government, and the entire community. And it'll happen at home where you live and raise your children. A little bit about myself. I am an emergency physician of many years. I previously have been the director of the emergency department at Scripps Mercy Hospital in San Diego, and I've been working with my community locally on the issue of safe prescribing and opioid epidemic for over 10 years. I helped the San Diego Coalition and various coalitions around California and around the country in getting together the people on the ground, the people who are making a difference to make their own communities where they live, where they raise their children, to be safer and better. And that's what's brought me here to the White House, and now I am the Chief Medical Officer for the Office of National Drug Control Policy. I work here on health policy and still commute to San Diego each month and see patients and then apply that knowledge of boots on the ground to here at the White House and working on health policy. There's a reason and a passion to this work, as most people that I meet that are working on in this field, that's personal to them. It's personal to me, it's personal to Director Carroll, to the President, and to many of you. For me, the child who touched my life and changed it forever is Aaron Rubin. He was a high school student who went to the same high school as my 4 children and succumbed to an overdose of Percocet. He did not die, but it left him a paraplegic. He can now only sign 1 for yes and 2 for no. And he took this tragedy, him and his entire family, to go out to the public to educate and make sure that that does not happen to other people. And now I want to give you some background about ONDCP. Our agency is part of the Executive Office of the President. Director James Carroll is confirmed by the Senate and is the primary advisor to the President on drug policy issues. Director Carroll is passionate about this work and brings the mission of saving lives to our entire staff at ONDCP. ONDCP is charged with coordinating drug policy across the federal government. We have budget oversight of the agencies that are involved with issues relating to drugs. This includes expected agencies such as National Institute of Drug Abuse, SAMHSA, DEA, and Health and Human Services. But it also includes agencies that have more indirect relationship to drugs, such as Department of Transportation, Department of Homeland Security, Labor, and Treasury. Overall, there are 16 and soon 18 federal agencies whose budget is controlled by ONDCP. The President's 2021 budget will include a record $35.7 billion to address every aspect of the addiction crisis, more money than ever to support this mission. ONDCP drug policy is guided by the National Drug Control Strategy. The strategy is focused on prevention, treatment and recovery, and reducing the availability of illicit drugs. This year, in addition to publishing the traditional strategy, our office published a historic national treatment guideline. The treatment guideline includes 3 pillars, 22 focus areas, and 6 factors. This sets a framework of the federal government as well as to you, our stakeholders, to bridge the addiction treatment gap. The pillars are improving early intervention, treatment recovery and infrastructure, improving delivery systems and providing efforts for substance use disorder, and improving quality and treatment. We very much count on a federal, state, and local approach to addressing the vast aspects of addiction. We will soon be working on voluntary consensus standards for addiction treatment. This will be a historic project with the medical field, and you will be hearing more about this in the future. Within ONDCP, we have a public health education and treatment task force. This task force provides strategic direction and guidance to interagency efforts to plan and manage the public health aspects of the National Drug Control Strategy. We have several projects at ONDCP Public Health Education and Treatment, and they include primary prevention, recovery support, substance use disorder treatment workforce, criminal justice intervention, and prescriber education. The need for addiction treatment is shown by the data from the National Survey on Drug Use and Health. In 2018, 21.2 million Americans needed treatment for a substance use disorder that included alcohol and drugs, and yet only 11.1 received specialty treatment. This defines our treatment gap. There has been a national alert on the volume of opiates prescribed by the medical community. This slide from IQVIA Institute shows that opioid prescriptions peaked in 2011 in terms of morphine milligram equivalents, or 72 pills per adult American. We must remember that there was a national push in the 1990s to address pain and to use opioids, and the medical community responded. Now we see the effect of the medical community responding to the opioid crisis. Since 2011, there has been a 43% decline in opioid volume, and 2018 showed the largest single-year decline in prescription opioids in history at 17%. Since 2011, there has been a 43% decline in opioid volume, and in 2018, we saw the largest single-year decline in prescription opioids in history at 17%. While opioid prescriptions have gone down, how has this correlated to mortality? Total opioid mortality from medications has gone up. This includes all opioids available by prescription and includes hydrocodone, methadone, and fentanyl. It excludes heroin. On the right of this chart, the circles show the division of opioid prescriptions, pseudo or synthetic opioids other than methadone, and the overlap of the two. You see how the total number is driven by the red circle, pseudo, synthetic opioids other than methadone, which is overwhelmingly due to fentanyl. Over 90% of pseudo is fentanyl, and the overwhelming majority of this fentanyl is illicit, not from prescriptions. The yellow bars in the graph represent prescription opioids that exclude any pseudo or fentanyl. This shows a rise peaking in 2011, followed by a decline. The mortality due to prescription opioids that exclude pseudo or fentanyl has declined along with prescription decline. But let's take a look at mortality due to unintentional overdoses from all medications that exclude illicit drugs. As we, the medical community, where should we be? The President's State of the Union highlighted an increase in life expectancy for 2018 to 78.7 years. The opioid epidemic hit our nation hard to the point of decreasing the life expectancy in the past few years. It's nice to see the needle moving in the right direction, but we are still lower than 2014 for life expectancy, which was 78.9 years. The CDC reported a decrease in overdose deaths by a rate of 4.6% from 2017 to 2018. The total was 367 people who died, down from 70,237. Our big threat remains fentanyl, with an increase of 10% in deaths from 2017 to 2018 related to pseudom, synthetic opiates other than marijuana. When I look at mortality data, I'd like to differentiate the supply chain. Everybody who dies from an overdose is our patients in terms of preventing addiction and treatment. But as far as supply chains, there's two different ones. The illicit market of heroin and methamphetamine and drugs that are pouring from outside our country and within, as well as the medical supply chain. If you look at the red bar, you'll see the medical supply chain, and those were started to peak in 2011 and includes all medications. It includes opioids, benzodiazepines, and various medications. And I suggest that the medical community focus on the prevention efforts on this red bar. And to do that, we need to think about opioids as well as all medications, all central nervous system medications that work together and increases the chance of accidental overdose. This slide is from a study I conducted in San Diego looking at all accidental deaths caused by medications, not illicit drugs. The colors show the various medications that are involved. While opioids are number one, the red ones, you could see that there are many other medications. But close behind are the blue color, benzodiazepines, as well as sleep medications and stimulants. All these are a factor and work additively to increase potential for overdoses. That's why when we talk about safe prescribing, we need to think about multiple medications and multiple prescribers that need to give coordinated care. There are many aspects, as I mentioned, to safe prescribing. The federal government has provided some important clinical tools, such as the CDC opioid guidelines, the Health and Human Services tapering guidelines, the FDA REMS education, support of the PDFP system, naloxone recommendation. I currently lead the ONDCP Safe Prescribing Work Group, and we are focused on the concern of concurrent CNN depressants, such as opioids and benzodiazepines. There's a high percentage of opioid deaths that include benzodiazepines, and recent studies show that the combined prescription practice remains an opportunity for education. Another public health priority is increasing access to medication-assisted treatment. You may have heard that the National Institute of Drug Abuse and SAMHSA are sponsoring a $500,000 a year grant on research called the Healing Community Studies. This grant is awarded to 4 states, Massachusetts, Kentucky, New York, and Ohio, with the goal of decreasing overdose by 40% in 3 years. Since we're talking about building a movement and focus on communities, I encourage local coalitions to look at the communities that heal intervention. And even if you're not one of those states that are awarded a grant, you could still use those similar tools and models. Another project that we are working on and is critical to the addiction crisis is building up the addiction medicine workforce. Out of 1 million doctors, only 5,000 are addiction medicine doctors and psychiatrists that are credentialed to provide that care. It may be 5,001 since I recently passed my addiction medicine boards. To put things in perspective, we have only 59 fellowships now of addiction medicine across the country, with the goal of 125 addiction medicine fellowships in order to build the workforce and infrastructure we need to treat our population. Another project, an innovation at ONDCP, is shared with the Department of Homeland Security and the National Security Council, and it's called Community Response to Drug Overdose, or CREDO. This is a project about linking in the work by the medical community and healthcare, law enforcement, and prevention together in order to save lives. Let me share a story from our emergency department. The other day, I was working and received a patient by the paramedics who came in with severe agitation after getting a dose of naloxone. In California, we have a big problem with methamphetamine. And the teaching point is that patients who come in with a potential overdose may not have the classic pinpoint pupils and sedation because they have mixed drugs on board. My patient required to be intubated and be placed on life support because he was not breathing well. I did a urine drug screen, and it was positive for cocaine and marijuana, but negative for any opioids. I was able to add a urine fentanyl qualitative test, which was positive. And he went to the ICU, and that could have been the end of my involvement with this patient. But I had a third-party responsibility, realizing that whatever he took may be exposed to other people in the community. And I was able to call our Overdose team, which is a group of law enforcement that responds to overdoses. They are specially trained in doing that in order to save lives. By doing that, they were able to come to the emergency department and identify my patient. He came in as a John Doe. They identified him. They were able to connect him with the family. They were able to go to the scene and talk to people, and they found 3 other people who were suffering from chest pain after taking this pill that they thought was a Percocet, but turns out to be fentanyl. The law enforcement agents have a mass spectrometer in the back of their car, and were able to test the pill and tell almost immediately that this was fentanyl. Those 3 people came to the emergency department, and while I started with 1 patient, I ended up with 3 other ones who were having chest pain and was able to treat them. And not only that, the officers were able to take and eliminate the supply of that illicit fentanyl and save countless lives. So by working outside the traditional silos, partnering with other people in the community, instead of saving the 1 life that was in charge of me, that I had in front of me at the time, it turned out to save 3 others and maybe countless others by eliminating that source of fentanyl. Think about if I had a case of 3 people who came into the emergency department with diarrhea from a single restaurant. I would want to call public health and find that source of potential salmonella and romaine lettuce or whatever is causing that and eliminate that threat. I think that we should think along the same lines when we talk about overdoses that are even more lethal. I really want to thank everybody who is working on the ground in building a movement. You will be the ones who will make the changes that are necessary in your local community. And I thought about some tips that I would have about building a movement. And let me share about 5 tips that I was thinking for you. Number 1 is to find the resources you have in your own backyard. You have them. You have the medical community, the law enforcement community, the faith-based community, the criminal justice, the government. You have everywhere across America the components that are important to create a coalition and to create a movement. That's tip 1. You have those resources. Number 2 is to take those people and break the silos. While we each work individually in our own lane, the real solution would be cutting through those silos and working together and sharing information, and you will enjoy that work because you'll be inspired, but you'll also make a bigger difference. Number 3 would be to use the face of addiction. Each of you have people who have been touched by this epidemic, who have died or are in recovery, and use their voice. It is very powerful in making the clinical or health policy points that you need to make in your community. And tip number 4 is to think outside the box. We've put a lot of tools in front of you that can be used and suggestions, but working locally and thinking creatively, you may come up with something new and even better and use that. In my community, I said, I'm going to write prescriptions for naloxone to anybody who has them and pass them around just like the pharmaceutical industry did to me 20 years ago in giving me free written prescriptions for opioids. There's a lot of innovations and use your creativity. And finally, celebrate your successes. You can try many different projects. Not everything works, but when something does, celebrate that as a community, and together you are going to, make America great and safer. And again, thank you so much for what you do every day and for building a movement.
I will continue speaking from the table here. Just a couple of brief remarks. It was really amazing for me to get two very, very different but very complementary perspectives from our keynotes today. Now we're going to dive deeper into who the sectors are that are doing this work and get a chance to hear from this amazing panel. We were just looking at the final Wordle, and a couple of things came up that I want to share with everybody. Really big words here: hope, community, collaboration, awareness is powerful. So with that in mind, I'd like us to think a little bit about how we can force multiply through the great work of the people here at the panel, but also everybody here in this room. Everyone has something to offer. Everyone has something to give. We all have many things to learn, but this is part of what I want us to be developing is a method, a system of connecting with each other in a very powerful way that really amplifies the value of collaboration and gets us closer to where we need to be as a country. So let me start by introducing the panel. This is an amazing panel. We've got a number of sectors represented here, and I'll start on the very end, introducing Cindy Cipriani. Thank you, Cindy. I know you had a flight, you just dropped in on us, and thank you so much for making it here. Cindy is an assistant U.S. attorney located in San Diego, and next to her is Milano Hardin, who is the president and founder of the Genius Group and has worked extensively in philanthropy across the country. Milano is located in Atlanta, Georgia. Next to him is Dr. Matt Willis, who is Marin County's local health officer. And then finally, James Wilson, who is Plumas County Public Health Agency Health Education Coordinator. James has been with us since the beginning and really has a very powerful way of representing what's going on in the more rural parts of California, and very, very powerful about the role of collaboration and how needed this is to get to where we need to go. So I'm going to ask each of you, we'll start at the end, to provide a brief description of yourself and how you got involved in this work. And actually, there's one thing I forgot to mention, I'm sorry. Anybody in the listening audience who wants to submit a question can do so by going to the Q&A box on your screen. And anybody who's in the room who wants to submit a question, there are sheets of paper on your desk, on your tables, so please write your question down and raise your hand. We're not going to take any voice questions because it's a little hard to mic. So please, Cindy.
Okay. Is this on? You can hear me? Yes. Okay. So, like Ranit, I also have a personal connection to the opioid crisis. My ex-husband was one of the patients that was being treated by primary doctors who were viewing pain as the sixth vital sign and giving him unending opioid prescriptions. So he basically went from being a very successful stockbroker with 2 kids who coached Little League to being basically homeless, and is right now, I think, kind of dying a slow death in the Philippines. I mean, he actually went and moved to the Philippines because he could continue to get opioids there when California doctors stopped giving them out. So it's been a really painful experience for me to watch, and it's an issue very, very, very close to my heart. So I had the opportunity a couple years ago to take part in our local prescription drug abuse task force. And basically the Attorney General at that time, it was Eric Holder, he'd given instructions to all of the U.S. attorneys and said, you know what, I don't want you to just file charges. I want you to be collaborative, work with your communities and find solutions. And he asked every U.S. attorney specifically to do something around the opioid crisis. So I was very fortunate to step into our task force at that time, which was created by Dr. Love, who you just heard from, and a DEA agent who was noticing more and more deaths from, at that point, oxycodone. This is really before the arrival of fentanyl on the scene, and also noticing that people were starting to switch to heroin. So they had already created this coalition, and what we realized was missing was we didn't really have data and statewide information, and we decided to host what I think might have then been the first opioid summit that was statewide. And all 4 U.S. attorneys collaborated and co-sponsored this event, and it was a really powerful event that brought together public health, law enforcement, individuals from the addiction and treatment community, family members, and it was a galvanizing conversation. And for example, the U.S. attorney in Sacramento realized that his district had the highest overdose rates, and he had no idea. He'd never seen that data before. So following that, we saw the opioid, the surveillance dashboard, a lot more data, and we've been hosting these summits every 2 years, and every time we host one, we see a huge increase in what's been done in the 2 years before, and a renewed commitment to work on the next steps. So I've been involved in now 3 of those opioid summits, and I think while the problem has changed and we've achieved some moderate success reducing the actual prescription deaths, what we're seeing in fentanyl has been frightening. And so our role in San Diego, we are really the gateway to fentanyl coming from Mexico from these synthetic labs to the rest of the country. We've seen our fentanyl overdose rate triple in 1 year, and it's continuing to rise. I've seen everything from a toddler who found a pill that fell out of his dad's pocket, took it and died, to a 20-something woman who lost her fiance. They both took the pill. She was passing out while she was trying to perform CPR on her fiance. A 14-year-old just got one at school and died. And so it's been a huge, huge challenge for us, but we have been working with a number of different sectors to collaborate on this, and I think it's collaboration, the kind of collaboration that Ranit described, where you see an overdose in the hospital and you reach out to law enforcement, and law enforcement can figure out who is the person from that overdose, who else was there, what can we do to get those drugs off the street. So I do feel law enforcement plays a huge critical role in this. We touch almost every part of it, and I'll talk a little bit about that later. But for those of you who are anticipating creating coalitions, if you don't already have one, it's not always easy to get law enforcement at the table. And I've realized that working with my colleagues, they care very deeply about this issue, but they see their role as we're getting the drugs off the street and we're prosecuting these crimes. And so it's a bit of a mindset to take them out of their silos, especially when they're as busy as we are on the southwest border, but it's really critical to have law enforcement at the table. So if you don't meet success with person number 1, I would urge you to keep going, and if you need to meet with your U.S. attorney, your district attorney, and ask them to assign someone to this issue, because it does make a huge difference to have law enforcement at the table and collaborating across sectors and you know, making things happen, helping to make things happen.
Good morning, everybody. It's a real privilege to be here and to add my voice. So I'm Milano Hardin, and I do currently run a strategy firm that works with private foundations and organized philanthropy, particularly those parts of philanthropy that are really attuned to the role that authentic community engagement can play in health, education, with children, youth, and family, and also around kind of equity and improvement. Our firm kind of has, for 20 years, worked in those sectors of philanthropy. But I want to take a step back in terms of who I am, because honestly, my career began in Cook County in a Cook County hospital in Chicago, really on the south side of Chicago, and the reopening of Provident Cook County Hospital in what was a portion of Woodlawn, a real tradition of urban poverty, a community, mostly community of color, that had kind of been forgotten as it related to health access. I am very passionate about the ways in which, as we imagine strategies to any kind of community health improvement strategy, even born in a time or a moment of crisis, how do we actually reimagine those moments as opportunities to build the long-term determinants of community health? to both be present to the sort of critical factors in this instance of overdose prevention. And we know that there's a 3x3 here. There's sort of an above the water, so there's an element of this work that really will require the attention, the skills, the savvy of physicians to change their prescribing practices, of pharma, to think about supply. We get that part. There's another part of this crisis which is kind of below the line that deals with life stress and hardship and behavioral factors that are tied to the enduring fabric of community. So I think my perspective here is, how do we sort of see this particular crisis moment to not just frame it as a technical challenge that would be addressed by, medical superstars on the stage, but to really see this as an opportunity to work across boundaries in ways that make this an adaptive challenge for building long-term capacity for community well-being. I want to represent sort of that perspective.
Thank you. I'm Matt Willis, Public Health Officer for Marin County. I love that my title there is Marin County Local Health Officer, and I think I want to change that to my official title because I think it really does reflect my deep belief that all public health is local. And following up on the points that were just made, our belief and assumption that the solution to this epidemic actually lies within our communities in the fabric of where we live, work, play, worship every day. I also have to start with, I think, the same, the ironic, introduction that Kelly offered in terms of my role started as an internal medicine doctor. I prescribed opioids. I graduated from medical school in 2000, and I'm part of the problem in the early part of my career, and it's been one of the most gratifying aspects of my work as a public health officer to try and address the consequences of something that I inadvertently contributed to. I also love seeing Ronit talking to us from the White House. So our journey in Marin County actually began with a conversation with San Diego. We, in 2014, just after I became health officer, looked at some data around our community and saw that our leading cause of accidental death was opioid overdose. And at that time, we had no infrastructure at all to deal with that. I had a public health team of about 100 individuals dealing with lots of different issues, but not one individual was actually dedicated to opioids, and that was true nationally. There was no local public health infrastructure to deal with the opioid crisis, and yet in most communities, the leading cause of accidental death was opioids at that time. So it was obvious that we needed to address that issue, and the first place we thought to look was outside. What else is happening? And we saw that this glimmer of light in San Diego under Ronit, where she had developed, and in collaboration with others, had developed a local coalition. And it was through borrowing that model and applying it into Marin County that we were able to develop our own opioid safety coalition called RX Safe Marin. And the assumption there was that, again, the solutions for us were within our community, and we convened, one day in 2014, all of the sectors that touch this epidemic, and an open invitation around an open question. How can we, as a community, prevent the harm of, at that time, framed as prescription drug abuse, and save lives? About 100 people came on that day, and it was out of that grew the RX Safe Marin Coalition, a collective impact model to address this epidemic. That model was then spread after San Diego and Marin into other communities, again, recognizing that by opening ourselves and actually reaching out for help and offering help to other counties who were building similar coalitions. And then California Opioid Safety Network came and expanded the number of county-wide coalitions where we were able to support one another between counties. And so I see this, the NOPN, the National Opioid Prevention Network, National Overdose Prevention Network, as really expanding at scale what we've seen as the successful model for actually reversing this epidemic that started at the local level. So when I think of building a movement, it's something that starts at the grassroots, and it truly does have its origin at the grassroots. Government isn't going to solve this problem for us. We're going to have to solve it ourselves. As a clinician, I mean, obviously the government has an important role to play. I don't want to be dismissive of that, but its role is really primarily in supporting local work and strategies that are proven to work at the local level. As a clinician, I think one of the, it's clear that we want to break down silos. Everyone's been saying it's all hands on deck, we need to work together. The how becomes very important, and Kelly touched on this. It's not enough to simply wish to collaborate. There are specific strategies that actually enhance successful collaboration that we have been able to refine in California through the California Opioid Safety Network, and other states have also been working in this way. And my hope is that by participating in a national forum, we're actually able to learn from one another. What are those best practices of the how? So if you are able to build that infrastructure of local coalitions, what specifically are you doing in your communities that's actually making a difference? And we know that there's excellence happening. There's been islands of excellence throughout California, and we've been able to identify those, amplify those, elevate those. And that's been one of the reasons for success within California. We know that's also true for the nation. And so I'm really excited about joining yet the next scale of this movement.
Thanks for having me. My name is James Wilson. I work at Plumas County Public Health Agency and facilitate our 4-county opioid safety coalition. I want to just talk about a little bit about the work of our coalition and just what we've been able to accomplish. We started in 2015, and it was really just kind of a reactive response. At the time, we had the highest rate of overdose deaths in California in Plumas County, and we knew that we had to do something about it, and we wanted to do it as much as we can, and with the limited resources that we had. That's also kind of why we formed a 4-county coalition, was because none of our counties had a lot of resources, and so we had to join forces just to be able to make this happen. When I'm talking about resources, I'm also talking about services. When looking back about 5 years ago, we didn't really have a lot to offer for people who use drugs. We basically it was up in the air, just if the only option was for them to either quit cold turkey or that's about it, basically. So we just kind of looked at what do we need to do to start really influencing change here. And it was a whole spectrum of things. It started from, from prevention to expanding access to medication-assisted treatment, which we had zero access at the time in the whole region. And also implementing harm reduction strategies, including syringe services and naloxone distribution. We've had a lot of successes in that regard too. We just kind of chipped away at them all, and now we have a much lower rate of overdose deaths. I guess on a personal level about what got me involved in this work to begin with is I was born and raised in the community that I live now in Plumas County. And I moved away for college, and then eventually I moved back to Plumas County wanting to raise my family there. And when I came back, there were several of my friends and people that I knew closely that died of overdose deaths. And it wasn't really unique to me. I mean, this was something that affected our whole community and pretty much everybody in the community. And so it was just, I guess, more so born out of frustration that we needed to do something, and that what we were doing before, which was nothing, wasn't working. And so we just started this coalition, and it's been a really, really great time, and there's been a lot of successes.
So I want to thank each of you for sharing a little bit of your personal story along with the sector that you have been engaged with. I think there is a lot to say, and you've already started the conversation about what partnerships can produce. I mean, you've lifted up the idea that people that are too far away to help each other actually with concerted effort can come together and create a reservoir of resource for a community. And we've also heard that people working within the justice system can look at the purpose of their work in a slightly different way to really connect with the others who are in their communities, and that through that connection can can move an agenda forward that saves more lives. So it's not just about the folks in front of you, it's about reaching out even further into the community through partnerships to make sure that we're really saving as many lives as we can from something that gets out of control so very easily. I want to ask now if our partners, really our partners here across the table could speak for a moment on some of the specific strategies that they have found useful in improving or increasing the inclusivity of other sectors.
Carmen, I'll jump in just to kind of warm us up and get us started. I'm sure my colleagues have lots of thoughts. I actually want to take one step back before we kind of lunge forward, which is there's something about the complexity of the epidemic that we're dealing with at hand that I actually think bears a little bit of reflection and a little bit of reframing. The reflection part is I really do think we are in the midst of a sort of a national challenge that needs the technical proficiency of physicians and medical staff and folks. So I actually want to really acknowledge I am not a physician. I'm trained as a health administrator, health policy analyst. I have a graduate degree. I looked at leadership. There's a part of what we're up against that actually gets down to medical prescribing. It gets down to pain management. It actually gets down to the neurophysiology of susceptibility. And those three areas really are above the line. So we do need to be in a kind of a powerful and dynamic relationship with the medical community. Here's the challenge, and here's the reframe. I also think that when we have community challenges that have a strong technical edge, that sometimes we over-center the energy around strategy with those professionals. And as a so when I was at Northwestern in undergrad, I had the opportunity to work with John McKnight. And it was really life-changing in the sense of his sort of appreciation of the role and the gifts that professionals bring to communities, but also the ways in which sometimes when we over-focus the strategy on the professional talents and not enough of the energy and the strategy focus on the community residents, we end up installing practices that don't get sustained over time. So to your point about what's the role of inclusivity in terms of sustainability, it is, I think, an opportunity for us to reflect on so many failed efforts at community resilience and community change that actually did not install community residents, that did not sort of imagine how their self-determination, how their inclusion, how their voices were going to be critical for a longer-term incorporation of those strategies and solutions into the fabric of community life. And I want to be specific. So when we think about community folks, the part that, my wife is a physician, the part that falls way out of what Joan would do at Kaiser is the reality of the origins of that life stress. Is the hardship that people are experiencing in communities because sometimes their communities don't have all of the essential resources and elements that are necessary for an equitable kind of experience of life that makes them whole and complete in their community. So the quality of those resources, the affordable housing that is necessary for them to have stability in their daily experience, high quality foods that are accessible in a kind of a geographic range, fitness resources so that they have practical ways to kind of access that daily dopamine that Kelly was talking about through exercise. We've got to be able to not just see what's happening above the waterline as it is manifested in a doctor's visit or in a critical event that happens in community, and to see that a lot of times these antecedents are being incubated in community and families, and therefore partnering with the agencies, the other support folks that are holding our communities and families, figuring out ways to bolster families' resilience actually ends up being an important part. And while we definitely need the gifts and the capacities of physicians and public health folks, we've got to figure out how to have authentic community voice and translation. So let me just make one other point, and then I'll hand it over to some of my colleagues. If you listen to our words and our discourse and the language that we use, sometimes it is very hard to access all of what this means. The language is so professionalized. We are using words that have meaning to us as professionals, but don't always have meaning to folks who are kind of living in their everyday experience. So again, I guess the reimagining, the moment of reflection, the pause, and the bit of a reframe is, how could we see this as both a technical and adaptive challenge? How could we see it as a challenge that is above the line? So yes, we need to look at medicine prescribing, pain management, neurosusceptibility, but we need to look underneath and look at the antecedents to life stress, hardship, and the unevenness of the social determinants of health that in fact end up being the engine for incubating the distress that then manifests in these critical events that we're trying to address above the waterline.
Primary prevention of substance use disorder as one of the elements of the national response, and that is that if we think about what that actually represents, what is primary prevention of addiction? You're moving upstream. So I think when it comes to prevention, one of our key strategies has been preventing new addictions. A lot of that work has been safe prescribing, because we knew that prescribing was one of the sources of opioids that were leading to addiction and then illicit use. That was, in some ways, the easy part, and we had a lot of success there, and we still need to be working in that domain. But if we think about adverse childhood experiences and some of the deeper determinants of actually what drove that person into that visit, seeking, I mean, one of the other strategies, right, is reducing benzodiazepine and opioid co-prescribing. You know, who is that person that the doctor is having a hard time not prescribing both of those medicines for, right? Because that's anxiety and pain, right? Or insomnia and pain. Or, I mean, what are you treating? Fundamentally, what are you treating for that person? And there's a lot of people who are taking both of those medications. That's one of the reasons it's one of the White House priorities. So I think it's inevitable, if we're really going to get in front of this, to go below the line, as you're saying. But to answer, you know, the also a more proximate question of how do you do intersector collaboration, I think one of the things we've learned is that we have a lot of low-hanging fruit in just some of the technical stuff across sectors, like law enforcement and healthcare. Right? It is a cross-cultural experience. I think many of us working in this domain recognize that on both sides. Language, assumptions about what we're trying to do. And I think one of the things we've learned and what we've been able to sort of highlight in some of the webinars and some of the teachings that we've done across the state and how to build a coalition and how to do that collaboration is identifying those areas where there are true interdependencies, where the common interests actually do align. And I'll provide an example. You know, we're working in Marin County to try and increase access to medication-assisted treatment in the jails. And it's something that historically has not been a priority for the criminal justice system. But it's an incredibly high-yield location to actually address the epidemic, because so many people who are incarcerated are also suffering from addiction. And in fact, maybe what's driving them into the criminal justice system. And so by looking at data, we were able to say, you know, about half of the people who are in Marin County Jail have a substance use disorder. And about a third of them, actually the substance use disorder, the addiction, that behavior was what landed them in the jail in the first place. So if they're interested in reducing recidivism rates, we can help, right? And it's a way of framing the problem in a way that your partner or your potential partner resonates with. You might use different language, but that's win-win space, and there's a lot of that. And I think that's one of the key strategies for us in this idea of breaking down silos, is it doesn't necessarily happen automatically. There's tactics to employ, and that's one.
Say from the criminal justice standpoint, we do also a lot of work in intervention and prevention of violent crime and gangs, and I can see an overlay between the prevention work we do in that arena and this prevention work. We use what we call formers, people with lived experiences. There's a particular gentleman in San Diego, Reggie Washington, who had a life sentence, ended up getting paroled, and he works to develop emotional literacy in kids. These are kids with adverse childhood experiences, kids that would most likely end up in gangs, and he takes them at the first point when they're introduced to the juvenile justice system, teaches them through restorative justice circles emotional literacy, and basically he said, you know, when I was young, I came up, joined a gang, and when I got angry, I used guns and violence. When I got depressed, I numbed myself with drugs. So that's where I think a lot of the root causes are, and I think there are ways to integrate messengers like Reggie Washington, who are working in communities that are beset not just by drugs, but by violent crime and gangs, and working this into their mission as part of it. And I think they can also be working with people in reentry, which many of those individuals do, and assisting them with, you know, peer navigation and recovery and treatment in reentry as well.
Yeah, I'm just thinking about the inclusive collaboration and just how that really, or what that results in. I know that we've brought a lot of different sectors to the table when we started our coalition, including our district attorney's office, our probation, and our law enforcement. And I think that actually our collaboration with our law enforcement has produced some amazing programs. At the very beginning of our coalition work, there was a lot of hesitancy from the law enforcement to really get involved in what we were really going for. And then it just slowly started with them just keeping naloxone on hand in the jail, for example, and for the law enforcement officers to have it on their patrol. And then it increased to them agreeing to give a dose of naloxone to anybody that requests it when they are getting released from jail. This is when they're really most at risk of an overdose because their tolerance is low, and so it helps them be able to come equipped with the tools. And now they're starting to induce patients if they request it and get them started on medication-assisted treatment at the time of booking. And just slowly but surely, like, these collaborations have just grown, and now we have just a great relationship where, you know, whenever there is an opportunity for us to help people in our community that are using drugs, then they want to be a part of it as well.
And it occurred to me as I was coming up here that the calls that I'm making to the sheriff and to the schools and to other stakeholders that are really concerned about coronavirus spreading in Marin County, those rails were established in the way we address the opioid epidemic together. So there are a lot of collateral benefits of building a strong coalition at the local level, because you're forming relationships that really are the kinds of relationships we need to solve a variety of complex social problems.
I actually want to build on this point. Another piece of me is that I'm actually hailing today from Atlanta, Georgia. There's a lot of California in the room, and there's a lot of GA love for California. But I also want to represent the experiences of, because I end up working a lot in the American South, so it's the 11 states of the American South, not including Texas. Texas is almost another South. I think it's really important to this. I want to make something even more crystal clear and tactical. It's not just reframing all of the human talent and all of the different sectoral contributors that need to be a part of the ecology of effort that help us when we're working on these kind of wicked, complex problems. I want to get really tactical. One of the things that's really, one of the strengths that I think Kelly acknowledged about the Center for Health Leadership and Practice, within that there's a 10-year investment by CDC that PHI and the center has been working on called the National Leadership Academy for the Public Health. There's actually coaches that are in the audience that are a part of that enterprise. We've had to use some very grounded practices like the use of a big picture, which is a tool for helping to map out more clearly the work and the roles, because if you have community actors at the table and you don't keep them busy, you don't help them see where they contribute, you don't map the problem beyond the medical transaction, beyond that medical office visit, maybe beyond a criminal justice event. If you don't map it more clearly into the community, it's gonna be hard. So I'm in the American South, so hear this through a different filter. It is going to be hard to build relationships with institutions that don't necessarily begin trusting. If people can't see their role, if you look at Stephen Covey's work on the speed of trust, he talks about two dimensions of trust, character and competency. It is not just the assent to your character based on your pedigree. It is competency. It is the ability to work with you on a problem where I get to have my power and my agency, and I get to see that I'm making a contribution as well. So I just want to lift up that this work about inclusion and authentic community engagement ends up being an accelerator for progress of moving down the pathway of a complex change. And that when we fail to give attention to this, we actually can move very quickly and not go very far.
Yeah. Milano, I want to thank you for lifting up that point, because it gives us a little bit of an opportunity to talk about why something like a National Overdose Prevention Network is needed. And let me just start by saying, for those of you who don't know, in running the National Leadership Academy for the Public's Health for the last 9 years, what my team has learned is exactly what Milano just said. You need certain kinds of tools and certain strategies. There's a skill set that's required to help bring different sectors together and to also really authentically have community in some kind of driver's seat, a serious driver's seat about specifying what is appropriate in their community, what they believe is needed in their community, what their community is ready for. I mean, what one community is ready for is going to be very different than what another community is ready for. Not to say you aren't all going to get there, you may, but without some very thoughtful, staged conversations and work, it ends up rolling up into chaos. So thank you, Milano, for lifting that up. I want to also ask the other people on this panel that have been involved either in the Leadership Academy or in COSN to perhaps lift up a couple of examples of why the strategies or the methods work on the ground. It may be the big picture, or it may be some other tool that you found useful.
When we first started, like I had mentioned, we were just definitely a very reactive coalition, and we finally got to a point where we had the opportunity to be more proactive. One of the things that we learned from COSN was we used the big picture tool to kind of map out where we were going and what strategies we were really going to try to emphasize on. And it led us to also go one step further and really strategically plan. We got a facilitator that was able to help us develop a 5-year plan. And I think that the important piece that I took away from it was the importance of figuring out what the shared values of a coalition is. You know, we have these different sectors that don't often intersect. And so we really needed to look into what it was that we all wanted to accomplish, and, you know, looking ahead, what do we want to see? And it was those shared values that really allow us to come together and work on something as a group.
Kind of on the other end of the spectrum of just practical support, I mean, there are obviously a number of threats to our collective success. One of them is sort of bandwidth. Most of us working in coalitions are wearing lots of other hats. So this is borrowed work, right? So we need to be as efficient as we possibly can be because we don't have time to develop, our own de novo, our own solutions necessarily, locally. We need to be able to actually borrow from work that has been practiced elsewhere, refine it, modify it, share it back, and that work is incredibly efficient, I think, from a state perspective, and it's why we called the accelerator program, right? It's an accelerator because that actually allows us to accelerate our work collectively. And lots of little examples of that. I mean, so naloxone. Now I learned that an opioid overdose was reversed in Humboldt County by a librarian because they carried Narcan at the library and they found someone in the stacks. That either happens kind of in isolation and no one knows, or you say, wow, let's learn about that. Let's get that person to come onto the state stage for a minute with other coalitions, tell that story, how they figured it out, did they have a policy, what was the protocol, how they teach the life, and suddenly you have that practice that was a wonderful innovation derived in a rural county spreads across the state much more quickly. And that's through the network. And it's a practical thing. You're posting the policy on the website. People can download it. It's converted from a PDF to a Word format, so you can actually modify it yourself. You can stick your logo on it. Those little things might seem trivial, but they actually make a big difference because when you only have an hour a day to give to this effort, you're going to get through that hour before you actually have that product finalized if you don't start close to something that's ready to go.
I would echo what Matt said. I mean, for many of us, this is a collateral duty. We're doing our regular job on top of this. We're often doing this in our free time. And also, there's often not a lot of money for things like prevention, billboards, messaging campaigns. And what I found when I planned the most recent summit is there are a number of different states, which is why I think it's wonderful to be taking this nationally, that have really creative programs that other areas could just pick up and run with. They would give it to you. They wouldn't charge you for it. They already paid for it, and it belongs to them. So for one example is in New York City, they were finding the cocaine was laced with fentanyl, and they were trying to find a way to get word out to people who were doing cocaine that it could be laced with fentanyl. They started a coasters and posters campaign in the bars. So basically, you go into a bar or restroom, because where are the people who do cocaine? Probably partying in bars. So they basically started this coasters and posters campaign, and it was designed to alert people about the dangers of fentanyl-laced cocaine. They also have a One Washington toolkit up in the state of Washington that has a lot of really powerful messaging. So these are things that can be shared if you have a county that doesn't have a lot of resources, either personnel-wise, to develop this kind of program and focus group test it, or to purchase it. I think that makes a big difference. I mean, in San Diego County now, our Team 10, which is our overdose investigation team, the agent came to me and said, I go and investigate these overdoses, and there are other people there who I know are doing the same drug, and they haven't died yet, but I'm kind of concerned for them. How do I get them into treatment? So we got a card together that shows all the treatment resources, tells them where to get naloxone. And then I learned that in Ventura County, because one overdose is very indicative that a future overdose for you is around the corner, they're giving everyone who experiences an overdose or almost overdose naloxone. So now we're getting that Ventura County toolkit, basically, and trying to implement that whole protocol in San Diego County. So I think there are so many great ideas out there, and if someone else thinks of it before you and goes through all the work and puts it all together, you can benefit from that, and we can start doing that on a national scale. It makes it really powerful.
Yeah, I totally agree. I think it's important to acknowledge that overdose prevention is nothing new, that syringe services programs and harm reduction programs across the country have been doing this for decades, distributing naloxone and have been teaching safer injection practices. When we started doing work towards harm reduction in our community, the only thing that we were really experts on was our own community. And it wasn't a matter of reinventing new strategies, but it was just figuring out who the right people in our community it would take to get these strategies in place.
James, can I just build one quick comment and I'll hand it back to you, which is, I don't know, there's a lot of folks in the room who've been in the medical community, the public health community for a long time, but before the big focus about 20 years ago on equity, there was a whole generation of thought and work that was happening around the CLASP guidelines, culturally linguistic appropriate services. There are things that we are, as we've shifted to look at collective impact, so FSG, and again, they are not the innovators of that work. There have been folks who've been thinking about collective action for many years across sociology and lots of different fields. We lost something when we stopped remembering to think about culture, conditions, and context in the way that the class guidelines had us think about much more systematically. My big point here is what's so exciting about this network, working across sector boundaries, working across cultural identity, is we get an opportunity to make sure we've got the right messengers. The message is clear. Sometimes what doesn't happen is that so much gets lost in translation culturally. Sometimes we're not really appreciating who the opinion leaders are in a community. We're not necessarily have the folks in the room and around the table who really understand how do you articulate a message that can be trusted and heard. And we are in the era of disinformation. I mean, we are in an era now where we don't just trust information because it came from a person with authority.
We're starting to get some excellent questions from our listening audience and some few questions from folks in the room here. And I want to thank everybody for that. And please keep those questions coming, because from your thoughts, we're creating some ideas for things to pitch to this panel and help see what kinds of issues we can raise. So I want to just follow on. We've mentioned a little bit about what specifically has happened in different communities, but I want to share one of the questions from the listening audience with, start with Milano. So Mr. Hardin, how do you feel about how the opioid crisis has affected the Black community? Some studies suggest that racial bias in prescribing shield us from a higher incidence of fatal outcomes.
So from the beginning, this is way out of my pay grade. In a lot of ways, I certainly don't speak on behalf of all of the Black community, and I don't speak necessarily on behalf of medical practice to the Black community. But I was reflecting on this morning, and one of the things that is a point of pause for me is it's so tricky that we have a crisis that has such a strong medical reality, that what happens with the pharmacology of this will have a big impact on individuals, no matter what race or ethnicity you are. There's the pharmacological, neurological impact of the drugs itself, and that is a reality. I think the thing that is saddening for me is that we also lose sight of the fact that so many folks in Black and brown communities actually don't have access to care. So when you begin from that awareness of that inequity, that structural inequity to treatment access, that is a point of sadness. And then you have the actual bias that happens, in the context of the actual provision of medicine for those who do have, either through access to the federally qualified healthcare movement or through private insurance. It's a great question. I do get stuck on the access to treatment issue.
Can I have just a follow-up on that? One of the reasons that we're prioritizing access to medication-assisted treatment in jails, it's almost automatic in terms of a racial equity lens because of the disproportionate incarceration rates of people of color. And if we are able to achieve actual evidence-based treatment for opioid addiction or opioid use disorder or substance use disorders of any kind in our jails, there will also be a corresponding benefit for that community that has been disproportionately impacted of color.
I think we have a huge amount to say on this topic. I want to make sure that we also cover a couple of other points. One is, what role do we see for people who are currently engaged in drug behaviors to be involved in the movement, and what role do we see in any, what kinds of ways have we engaged people who have been or who are currently using?
One thing we're starting in San Diego, we have waived into drug Medi-Cal delivery program, and there will be peer navigators, people who have lived experience with substance abuse. It's going to create many, many jobs. There will be training for those individuals, and peer navigators will be a very integral part of our treatment system. I think this has happened in numerous communities, I know, across the East Coast. It's a little bit smaller of a program so far in California, but I think San Diego County is the first county I'm aware of to make it an integral part of its treatment system.
I think it's imperative to involve people that use drugs in the policy development of anything that's going to affect them. Any good policy, when you think about it, you ask the stakeholders and the people that are truly going to be affected by this, first and foremost, how it's going to affect them. Otherwise, it's just not going to work. So I think that when we're developing new programs, and I know that we've definitely consulted people that use drugs and are even really encouraging them to help us do the work itself.
Yeah, and I would also add that the Bridge program that had started in Alameda County at Highland Hospital has felt that it's really critical to have what they are calling substance use navigators, or SUNs, as a key element in getting people recognized and trusting of the treatment opportunities within their community. And that if you don't have lived experience, you don't know where the issues are the most critical, you don't know how to communicate effectively and to help build trust with somebody who is in crisis, or maybe not in crisis, maybe just still thinking or contemplating, or maybe not even at that point yet, but that there's something that they know about having been there that makes a difference in helping to bridge that relationship and help provide that available opportunity if and when a user is ready to go into treatment.
The other reason that's so important is with Prop 47 and decriminalization, there are many fewer opportunities for law enforcement to get folks into treatment. So we need another way. We need another way to direct people to treatment. I'm not sure how effective it ever was for law enforcement to be getting people into treatment, but at least the idea of a felony hanging over your head might convince you to do it. So you've got the judge in the black robe up there. We need something to take the place of the judge in the black robe, and if it's a peer messenger who has shared that experience, who is living a better life, who can relate to what you're going through, I think it's much more powerful than using the criminal justice system. But we do need, we're seeing with the rising homelessness and with increased drug use, increased overdoses along the spectrum, not just opiates, but meth now. We have actually more meth deaths than we do opiate deaths right now in California. We definitely need people with lived experiences to play a role.
One important trend in that space, if we recognize that peer-to-peer support is so far superior, just categorically, to the alternative of a physician or someone else sort of trying to compel someone to behave differently. that it's a technical challenge, right, to actually sort of the number of individuals who need that kind of peer support and the number of people who can provide that. One of the solutions to that is there are promising new tech solutions to that, where you can have virtual peer support communities. And that's an example of an evolving strategy that I think we could accelerate nationally through a network.
So again, there's so much to cover here today, and we have a limited amount of time, but I wanted to touch on some big chunk areas. What kinds of strategies have you all seen in each of your work that engage youth in both prevention, but also that perhaps help to connect with youth in a way that can help them maybe reprogram their lives and their opportunities?
Want me to start? Okay. Well, in San Diego, we've seen a huge increase in the number of kids who are smuggling drugs across the border. Some of these kids live in Mexico. They have family in Mexico and family in San Diego, and they go to school in San Diego, so they cross every day, which makes them very attractive to the cartels. And we were seeing a huge spike in the number of kids caught with drugs at the border, and they get prosecuted by the DA's office. The federal system doesn't really have space for them. But we thought, how can we harness these kids to teach other kids about the danger? And we were particularly concerned when we saw instances of carrying, it used to be marijuana, then it was meth, cocaine, heroin, and now it's fentanyl, that they don't even know what they're carrying. It's strapped to them, they're walking across the border. They have no idea what they're carrying. So we did put together a juvenile smuggling prevention program and have taken it around to the schools, and we have kids who have participated in juvenile smuggling who are helping us work that program, present that program, be messengers for that program. And it's been so incredibly powerful, and we would love to extend that beyond juvenile smuggling to juvenile drug use, just being aware of the dangers. The focus of that program is basically not just don't do it, it's we want to empower you. Here is what you need to know if you engage in juvenile smuggling. Here is what fentanyl is and what it can do. Here are the collateral consequences, even if your conviction or finding is expunged when you're 18, that arrest will remain on your record and prevent you from all kinds of jobs in your future, will prevent you from joining the military. You will be on probation for 3 years. You won't be able to have a cell phone. You won't be able to drive. You will have a curfew. All the things the cartels aren't telling them, we are telling them. So, and they're hearing it from their peers who've been through it. So I think programs like that harness youth as peer group messengers, we would love to expand that to have the youth create social media, posters at their schools, essays, that the message really is coming from youth rather than from us, because I think in many ways they are the most powerful messengers. And if there's a way we can harness their voice to speak to their peers, that will be very powerful.
I wanted to lift up something that I see happening that is really promising. It's not only specific to overdose prevention and substance abuse, but it's also around other high disparity health disease conditions, which is the kind of the development of narrative change strategies that are about this simple notion that we can change the narrative by actually changing the narrator. So we're starting to see in the foundation community the emergence of fellowship programs, professional in-service programs that are targeted towards folks of color and that are using some different methods like appreciative inquiry, that are using asset-based framing, because the challenge is sometimes we problemize the populations themselves who we're trying to help, as opposed to problemizing the system dynamics, the structural reality, the systemic disadvantage that is creating a bigger set of conditions that's creating the challenge. So I think it's really promising to see these sort of asset-based frames that allow the folks who are perhaps more vulnerable to actually reimagine themselves and to see a narrator lifting up solutions that also is a person that looks like them.
I think one way to engage youth that we found successful is to sort of see this as an opportunity for empowerment and civic engagement. You know, when we've had various policies, decisions that had needed to be moved forward with the schools, you know, trying to encourage the schools to carry Narcan, and if there's, you know, little ways to say, you know, have the students themselves actually engage in that dialogue and bring it, offer some support and some evidence and a little bit of coaching, and then also, you know, but actually give the voice to them to actually be the carriers of that suggestion to leadership, whether it's leadership within the school community or even the Board of Supervisors. We had a policy where pharma was responsible for a network of take-back sites in Marin County and funded by pharma as an ordinance passed at the Board of Supervisors. And a lot of that was actually driven by voices from young people in our community speaking to the board directly.
Yeah, our agency facilitates like weekly groups in each one of our schools in our county, and it's a county where if you don't like to hike and fish, then there's really not that much for kids to do. There's no youth center or anything like that, so we have struggled with how we're going to present drug education to them. One of the things that has been successful is we took the morality out of drug education. We don't ever use the words good or bad, but instead just really focus on, here are the effects of this specific drug, and this is what it'll do to your body, and here's the effect of this one, and it's a completely different effect. And then also just being real with them and talking about, I mean, the illicit drug supply is completely inconsistent. You don't really ever know what you're getting, and so just showing them where resources are to help keep them safe.
I think one thing that's really important for you all to know that are out there listening and participating, we are not every point of view, and we didn't ever think that we could do that. But we did make some very careful selections to make sure that we could be as diverse as possible, yet still be able to be somewhat cohesive in a message that we could try to contain within a 2-hour period of time. This was not everything. We never intended it to be everything. It is only the start of a conversation. What we hope the National Overdose Prevention Network will be able to do is to help us to, you know, both segment when we need to into different interest areas, be that by geography or by issue, and then come back together and on an iterative basis to really keep growing our knowledge and growing our engagement and changing the way that we think in this country and act in this country around substance use and the various consequences. So I want to just go back to this group and start from the end, and two thoughts I'd like you to put together. One is, what are some of the strategic ways we can think about this going forward, and what does success look like?
Well, I think success looks like lowered overdose, like let's get to 0 overdoses, better education. For law enforcement, success is how do we disrupt, get the fentanyl, the most dangerous drugs, focus on the most dangerous drugs supply. And that's an important part of this, regardless of other aspects of law enforcement that I'm sure there are many different opinions about. I think all of us want to see no fentanyl on the street and no deadly drugs in people's hands. I think that a lot of this can be achieved, a lot of our goals can be achieved through better awareness and communication. And to me, success looks like collaboration and sharing among networks and between different sectors that are all working towards the common goal. And we've done a few things in San Diego that I think are translatable to other districts. So when we first started seeing fentanyl come out in a major way and reveal itself, we started having street drug trend meetings where all the line officers, along with folks from the paramedic company and public health, would get together, and emergency room physicians would get together and talk about what they were seeing. So those meetings have been extremely helpful. I think that's something that could be replicated in every community, and all of that helps you work towards 0 overdoses, along with school education programs, messaging programs, the kinds of efforts that will bring more awareness. And also, I think one sign of success is lowered stigma. At our first summit back in 2015, it was even Dr. Lev who said, well, I just don't know how I feel about medically assisted treatment. You're just substituting one addiction for another. And that just goes to show how far we've come, that we no longer feel that way. We don't really look at people with addiction as something anyone other than a medical problem, that this is a medical problem. We're not making judgments, and we're using people with lived experiences to lower stigma and to treat this as a medical problem. So to me, that's what success looks like, is better awareness, less stigma, and hopefully getting to lower overdose, no overdose deaths.
I'm going to be really, really quick because of time. I actually think that what's exciting about this moment that we're standing in right now together is we are coming together across all these boundaries of sector. And my hope is that actually that we get really clear about where we have opportunities for small and short-term wins in terms of specific reductions in overdose prevention, but that we leverage the winning to be more inclusive, to bring more partners into the tent, to see this as an opportunity to kind of grow our capacity for resilience. So I don't know, I both want to be very pragmatic, and I want to see numbers go down in places where we've started work that really matters. But on the other hand, I want us to grow the tent because I actually think we need to change the model to reach some folks who are going to be harder to reach.
As far as the strategies, I agree with Cindy. I think that really a whole spectrum of strategies is really what's needed, anywhere from prevention to treatment to harm reduction, just really meeting whoever it is where they are and just tailoring their own idea of what moving forward looks like to them, basically. As far as what success looks like, I think that it would just be having communities, just resilient communities where people can live stigma-free lives and can have readily access to services that will just reduce the harms that come from drug use.
So I want to just bring us back to a moment from where we started. Hope, community, collaboration, awareness is powerful.
Excellent. You all, this has been an incredible conversation. Can we give all of the panelists a hand? And I promise I'm not doing that to double dip. It has been an incredible morning, and already we can see the promise of what is possible when we come together across boundaries of sector, across perspective and role and profession. But also just as residents and citizens who care so deeply about this challenge that we're facing. And that we use it to build not just solution capacity for today, but that we actually reimagine ways that we could use this capacity. There are surely other community challenges that are at our heels. We have had the privilege of journeying this morning with a broad simulcasted audience that have been with us virtually. We've been over 400 folks representing 47 different states. It's been really spectacular. We're going to just draw your attention to one other opportunity that we have. We want to make sure that you go to nopen.org. Please register, please click and become a part of this incredible, promising movement. As you're there, you will also get an opportunity to complete a 4-questionnaire. It's an opportunity for you to offer insights and wisdom to us to help ground. It's a way for us to listen, and it's a way for you to get your voice into the circle. We've been thrilled to just have this morning. Thank you very much. I believe that we will have a break. Everybody, thank you. Please let's give our panelists one more round.